listen to it later, should you wish. So the talk has started now. Thank you.
Okay, Lucky, shall I take it forward from here? Can you
Please,
hear me
thank
okay?
you.
Yeah, perfect. Okay, look, thanks very much for the introduction. I'm absolutely delighted to be able to be speaking with you this evening. Really appreciate that. And thank you for the warm introduction as well. I wanted to sort of share with you, and I've got a few slides I'll come on to in a few moments, just sort of how the NHS in Lincolnshire is structured, why it's structured the way it's structured, the sorts of changes that we're going through, and then sort of what that might mean for clinicians, GPs, and first 5 GPs in Lincolnshire, looking to the future. But it's the end of I guess quite a busy day for us all. So I'm very happy to be in kind of semi-formal mode, relaxed, open conversation, a conversation amongst colleagues who we all have shared interests, and a safe space as well. So if there's something you want to ask me or say, or please don't hold back in commenting and questions. Very welcome. I'm joined today by my and our medical director, Dr. Sonil Hindosha, as well. Sonil will help keep me right and take all the difficult questions as well. So thank you, Sonil, for joining us for that. I wanted to firstly say a few words about the work of the First 5 group in Lincolnshire, because Leke, as you've mentioned, I've kind of been working alongside you for quite a few years now. And I just wanted to say that to start with, you all have my full support. I recognise that the early years of your clinical career are really important, and you're all key individuals as well as a key group in how we are developing and delivering healthcare in our county. I work, I think, quite closely with Ola and Leke on your behalf, who I speak with you quite regularly, and I hear and sort of track the work that the First 5 group does. And I must say, I'm hugely impressed by the way you organise yourselves, by how cohesive and dynamic a group you are, and what you're already contributing to the NHS in Lincolnshire. I've got a strong sense that the Lincolnshire First 5 group compares extremely positively to others that I observe around the Midlands and our neighbouring patches. So you're doing brilliant work, and I want you just to know that I'll continue to support you individually and collectively as best I can in the work as we go forward. And Lucky and Ola, thank you to you for your support to the First 5 group, and also to me in that. It is appreciated. The next comment I wanted to make is I recognise that you are all GPs in the early years of your career. I really want you to have a rewarding, satisfying clinical career. I really want you to have that in Lincolnshire. We need great GPs, don't we? The people we serve need great GPs. But I also recognise that you'd be very focused on your clinical careers, developing your clinical skills, focused on the needs of your patients, working with the team and the practices you're all part of, and how that is uppermost and first and foremost in your minds. And we've got 84 general practices across the whole of Lincolnshire. Hopefully, the conversation we can have together will help us to just understand a bit more about the health system in Lincolnshire, what's going on, and how we might fit into it. Because I totally recognise that a lot of leadership and management stuff about boards and statutory authorities and systems probably feels very remote from your day-to-day lives in trying to provide great care to the patients you're responsible for. So it'd be great to have a bit of a conversation about how we are all connected, because we absolutely are. So we're all part of this bigger thing, our NHS in Lincolnshire. And I want to step in now to my presentation to you on our health and NHS system, how the new structures and new ways of working are coming through, what our ambitions are, what we're trying to achieve, and the fundamentally important role of clinical practice and of general practice within that. So the next significant challenge I've got is seeing if I can actually get my presentation up for you all. It worked earlier, Lecky, didn't it? So let's see if we can do it again.
Yes, did.
Okay.
Looking positive.
How does that seem? Was that okay?
Excellent. Yep.
Right.
Nice and
Okay. Thank you. So you know what I look like, John Turner, the Chief Exec of the NHS Lincolnshire Integrated Care Board. Those of you who know me a little bit, hopefully you'll recognise that I'm a really strong supporter of general practice and primary care generally, and obviously specifically here in Lincolnshire. It's just so important. 90% of all the public's contact with the NHS is with their general practice. That means, obviously, for most of the people we serve, most of the time, the GP and the practice is the NHS in our communities across the county. So it fundamentally matters from that perspective. From Lecky's introduction, you'll know I'm an NHS manager and leader, but an NHS man sort of through and through. But also I feel quite passionate about health and care in Lincolnshire. What Lecky didn't share with you is actually I was brought up in Lincolnshire. So whilst my career has taken me all over the UK and Europe, I'm sort of Lincolnshire man, if you get what I mean. So it's my county, and health and care in Lincolnshire really personally matters to me. The next thing is that I'm really ambitious for health and the NHS in Lincolnshire. We have a lot of really difficult issues to work our way through. The demand upon our health service at the moment is considerable. The demand upon general practice is considerable. We've just come out of this pandemic. We're just about to step into winter. We've got a lot of issues that we need to work our way through. But I also really believe that there's a lot of fantastic stuff going on day in, day out, delivered by thousands of people in our health and care system in Lincolnshire. But when I'm speaking to members of the public, I do say to them, if you were seen by your general practice today, you were one of 15,000 people. Each and every day in Lincolnshire, general practice sees about 15,000 people. Phenomenal, isn't it? Absolutely phenomenal. And about half of those are actually seen on the same day that they contact their general practice. That's a brilliant service. I actually also think that being able to support clinicians to make a really great contribution to how the NHS around here develops, and having great clinical leaders, great clinical careers, and being very involved in how our service develops is a really, really important part of a successful health system. So let's just have a little think. Oh, I've done let's just have a little think. I've done it now about our county, because the way in which our county, the features and characteristics of our county impact on the NHS and the health of the population every day. So what do we know about Lincolnshire in geographical terms? Well, firstly, we know it is an absolutely massive county. Geographically, we're the 4th largest in England. So it's really big, and there's lots of it. It is predominantly rural and has a very long coastal strip. Population of nearly 800,000 people, very widely dispersed across our county the topography of the land is pretty flat, isn't it? So it's not like other rural areas that have got hills and mountains where people live in the valleys but not on the hills. There's a spread of our population across this whole patch. We've got 3 large population centres in Lincoln and Boston and Grantham. They are roughly about an hour's travel apart, aren't they? That's where our large hospitals are. We don't have any motorways. We've actually got fewer than 50 miles dual carriageway in the county. Most of that's up the western side. It's the A1, and we've got some very, very long country miles. I could go on, but the point is all of this impacts on how we run the health service and the health of the people we serve. When we think about the Lincolnshire population, actually inequalities are rife in the Lincolnshire population. We have significant levels of deprivation, and deprivation impacts on people's health, it impacts on their well-being, it impacts on their life expectancy. You may not know, but if you were to look at the top 20 towns in England and Wales, of the most deprived towns, we have number 1 and number 4 in Mablethorpe and Skegness. Very significant levels of deprivation. One of our areas has the highest levels of diabetes in the country. We have a higher than average elderly population. We have a significantly higher than average percentage of care homes in the county. And that across the county is significantly skewed to the east of the county. Our under 75 mortality, our levels of physical activity, our smoking rates, our levels of obesity in adults and in school-aged children are all the wrong side of the national average, some of them significantly the wrong side of the national average. And we have a significant number of people from an Eastern European background amongst the population we serve as well. So all of that impacts on the NHS, doesn't it? And you will see that impact day in, day out in your practice. And we know, just to layer on top of that, that we have significant workforce challenges in Lincolnshire. So the NHS nationally has roughly 100,000 vacancies in it. That's a huge number of vacancies. That kind of is spread differently across England. But here in Lincolnshire, we have more than our fair share of workforce challenges. And again, the further east you go in the county, the more difficult it actually becomes to recruit and retain, actually more to recruit actually professionals, be that healthcare professionals or other professionals across the private sector. One of the considerable assets we do actually have is, once people come and work for us and live in Lincolnshire, they tend to stay for a very long time, because it's a lovely county, the schools are good, the housing's cheap, and we can offer great careers in Lincolnshire. So it's not all bleak. There's a lot of really good upsides as well. And then the final point I wanted to make about Lincolnshire is that compared to most other parts of the country, the number of organisations in Lincolnshire is relatively small. So it's a relatively simple system to run and to organise. It's complex, but it's relatively simple. What I mean by that is, covering the population of Lincolnshire, we have one county council, we have one NHS integrated care board, we have one acute trust, one community trust, one mental health trust, one primary care network alliance, one care sector network, one third voluntary sector network, and one First Five group. all with the word Lincolnshire in their title. Now, most other parts of the country have multiple upper tier authorities, multiple NHS trusts, and a whole set of really difficult, complex arrangements. So just to share with you the system just to the north of us, which is the Humber and North Yorkshire system, has 6 upper tier authorities in it. We in Lincolnshire only have 1. So the Integrated Care Board up there has to work with 6 local authorities. It's just us and the county council in Lincolnshire. So we've got, those are really, really, I think, strong assets for us. So that's a bit about Lincolnshire. Let's think about the health of the population a bit more. Lucky, these slides I'll make available to you, so obviously you can spin them round, everyone. So here is a very simple map of Lincolnshire with our 15 PCNs boundaries in it, and which incorporate the 84 general practices that you're all part of, and how that maps on to 7 district councils. The next thing I wanted to share with you is a bit about life expectancy across the county. So you'll see in the 4 counties PCN far left of there, so that's Stamford and Hereward practice, that the average life expectancy is just over 83 years. You'll see on the far right the Marina PCN, which actually is Dr. Handosha's PCN, or the first coastal PCN, which is the one out at Skegness and Mablethorpe. They are at what, 77, just into 78. So there's this huge difference there in terms of the average life expectancy of our population. If you were to actually drill that down to district electoral wards, that difference in Lincolnshire is 18 years. So from the most deprived wards in life expectancy, which is actually South Gainsborough, to the highest in terms of life expectancy, which is just north of Bourne, 18-year difference in how long on average the population lives. That's staggering, isn't it? Absolutely staggering. And this is our deprivation map. Again, this is simply a heat map of deprivation across the county. What your eye is immediately drawn to is the east and the coastal strip, isn't it? We know there's staggering levels of deprivation out there. One of the issues about this map is that some of the smaller blue dots actually cover a significant side of the population. It's just in a very tight geography. So not only do we have issues out on the east and Boston, but we also have issues in Gainsborough, Lincoln and Grantham in terms of significant hotspots of deprivation. The Chief Medical Officer, Chris Whitty, his 2019, I think it was, annual report really focused on health inequalities in coastal areas. And actually, our coast was one of the 10 areas that were featured heavily in that. Okay, the reason why I wanted to talk about the county and about deprivation is that the way in which we organise ourselves as a health system has to respect and work with the dynamics and characteristics that I've just shared with you. So there has been a restructuring of the NHS in England. Have I finished my slide? Oh, sorry, I haven't actually finished those slides. Bear with me, I'll just go back a bit. So the burden of disease And this is provided by our Director of Public Health, Derek Ward. So in very simple terms, the column on the left is years lived with disability. Column in the middle is years of life lost due to premature mortality. And the column on the right, disability adjusted life years, is essentially the sort of sum average of the two. So if you to look on the left hand side, so this is essentially what people are most ill with, is a way to look at this. The top 5 are low back pain, diabetes, depressive disorders, headache disorders, and age-related hearing loss. And I'm sure you'll see a huge amount of that in general practice day in, day out. If you look at the middle column in terms of what actually kills people, it's ischemic heart disease, lung cancer, stroke, COPD, and lower respiratory infections. And then if you look at the right-hand side, so that's the top 10, and the top 5 are ischemic heart disease, COPD, low back pain, lung cancer, and stroke. So this is a really helpful way to think about what are the most important things that affect both the health and the life prospects, really, of the population of Lincolnshire. One of my colleagues told me something just a few days ago I thought was pretty staggering, actually, that the percentage of the Lincolnshire population which is of working age but isn't working due to health and disability is twice the national average. Just think about all of that in terms of what that means, not just for the lives of those people and their families, but the loss of contribution, meaningful existence, and all of that to these people in Lincolnshire. It's about 35,000. It's a lot of folk. Right, okay. Now on to my next bit. So on the 1st of July this year, the NHS was reorganised. There's new legislation was brought in, and it established 42 integrated care systems as statutory systems across England. So the Lincolnshire integrated care system is one of 42. And we are all part of the Lincolnshire integrated care system. We call our integrated care system in Lincolnshire Better Lives Lincolnshire, because I think that's what we're all really working for here. And when the integrated care system was introduced, we were tasked with delivering on 4 core purposes. Firstly, to improve the outcomes of the health of our population in healthcare. Second, to tackle inequalities in outcomes, experience, and access. Thirdly, to enhance productivity and value for money. And finally, to help the NHS support broader social and economic development. So these are the core purposes of the integrated care system. So I, Dr. Hendosia, my colleagues, my partners, we are all working together to work out how we are going to do these things in Lincolnshire. So if we were to take the top left box there, I've just shared with you, the disability adjusted life years work and priorities. So how are we going to tackle those most significant clinical issues that are affecting the health of our population? I've talked to you about inequalities in Lincolnshire. How are we actually going to reduce inequalities in outcomes, in people's experience and people's access to care? So these are the things that we are currently working our way through. So we were established on the 1st of July, and these are really big challenges for us. And over the course of the next couple of months, we will have established an ambition for the integrated care system in Lincolnshire. and I think that will be about Lincolnshire being seen as and having a reputation as being a leader in rural and coastal health. And to do that, we know we've got a lot of transformation to go through. And I think that we will take each of these four and say, so over the next couple of years, what are we going to do about these in Lincolnshire? And develop an action plan, so to speak, for that. And I can come back to that in conversation, but our intention is to have that finalised by the end of March, so that that becomes our plan for the new financial year going forward. Within the integrated care system, kind of who are the key players in it? There are. This is quite a simple description of it. So, but hopefully it helps. So to start with, if I can kind of start in the middle with the yellow bit. So that's the NHS Lincolnshire Integrated Care Board, which is the organisation I'm the chief executive of. As Lecky said, I'm responsible for about £1.5 billion worth of taxpayers' public money. And my job is to use that resource every year and deploy it in a way which best meets the health needs of the population and manages the NHS budget and arranges NHS services. That's a very simple way to describe what the job is. Of course, most of the care provision is delivered by providers, and that's the column on the left, on the right hand side there. So who actually delivers care around here? If the Integrated Care Board is responsible for overall planning, who actually does the care delivery? And you'll see in there we've got general practice, we've got our large acute hospitals, we've got the mental health, so the acute hospitals in Lincolnshire is United Lincolnshire Hospitals. Mental health in Lincolnshire is Lincolnshire Partnership Foundation Trust. Community Health Services, the Lincolnshire Community Health Services Trust. Clearly, we also have pharmacy, ophthalmology and dentistry. We also have our ambulance services, which aren't on this list. I missed those out. We have our care and support providers. So that's sort of our care homes and our domiciliary care services. And we have our voluntary sector as well. Also, just to say to you that a lot of care for Lincolnshire population is actually delivered outside of Lincolnshire. So those of you working in the south of the county will know that for about 150,000 of our population, Peterborough City Hospital is their main hospital. For some of our population in the far southeast of the county, it's Kings Lynn, and in the north of the county, it's Grimsby and Scunthorpe. On the far west of the county, it's into Nottingham. And then, of course, when it comes to highly specialist services, they tend to be in specialist areas as well. So the Integrated Care Board, as well as organising NHS services within Lincolnshire, we also have to work with all of these other providers who provide care to the people of Lincolnshire. So underneath the Integrated Care Board bit there, we've got the County Council. So we know that they are responsible for adult and children's social services. They're responsible for public health. They're responsible for public transport. Obviously, there's a lot of other things as well, schools and education. And they are really, really important partners with us. In fact, I think in terms of improving the health and care of the population as a whole, you can make a strong case that they are a more important partner than the NHS. When you look at the population health, when you look at schools, when you look at economic development. We also, within Lincolnshire, have 7 district councils, and they're responsible for certain services at a much more local level: housing, leisure, refuse collection, etc. These are all really important services that impact upon the health of the population as well. So all of that takes me to the left-hand column there. It's called the Lincolnshire Integrated Care Partnership. This is a new partnership, statutory partnership that came in on the 1st of July as well. But it's a committee really that's formed between the Integrated Care Board and the County Council, but has that broad range of partners on it, all concerned with improving care, health and well-being of the population. So we have not just the health and care providers who are part of that and the district council that are part of that, but people like the university, people like the local enterprise board, people like the police are all involved in that integrated care partnership. And the job of the integrated care partnership is to pay attention to the health needs of the population and determine how we're going to work together to improve health and well-being in the round. So, luckily, those are the sort of core components of the integrated care system. In terms of the integrated care board in the middle there, which I suspect is the part of this system that general practice, kind of comes under, because all of the funding for general practice in Lincolnshire comes through the integrated care board, and all of the issues relating to general practice and primary care come through the integrated care board as well. Just to share with you that the integrated care board is an organisation. We have about 300 staff out of an overall workforce for the NHS in the county of about 13,000. And it's more than that in terms of the care sector. So we've got about 300 staff working in the integrated care board. So very small compared to the totality of the whole system. Our integrated care board has a board. So we have a chairman, a chap called Sir Andrew Cash, chief executive, myself. We have 5 non-executive directors, one of whom is actually Sir Jonathan Van Tam. You may not know that he's a Lincolnshire lad as well, and having JVT on our board here in Lincolnshire is a fantastic asset for us. We also have a medical director, Dr. Sonal Handosha, a nurse director, a finance director, and some other directors who are concerned with planning and primary care and things like that. And we also have members of the board who are from partners. So we have one from the county council, who's a senior county councillor, a trust chief executive, a mental health representative who happens to be the chief executive of the mental health trust, and also we have a primary care partner member on the board, and that person at the moment is Dr. Dave Baker. Dave is a senior GP in Grantham and has been involved in clinical leadership in Lincolnshire for a long period of time. So our integrated care board actually has 2 GPs on it, Dr. Handosha and Dr. Baker. So they have a significant responsibility to make sure that when we're considering the performance and the development of the NHS in Lincolnshire, that the clinical and the general practice voice is heard as part of that, and they don't hold back with that, I can tell you. So that's the integrated care system, and this is just a different way to sort of see the system. So in very simple terms, we've got Lincolnshire in the middle there, and we've got all of the key partners around that. So we've got the ICB at the top, then we've got the third sector, we've got the care sector, we have the Lincolnshire Primary Care Network Alliance, we've got 15 now PCNs in Lincolnshire, and all, I think 84 practices are part of our 15 PCNs. We have the 3 NHS trusts at the bottom, the district councils, and then the county council. What that's trying to represent is how we all work together in a shared way to improve the health and well-being of the population, as well as improve NHS services. I keep pressing the wrong one, don't I? I said that this new integrated care system came in July. What sort of actually is the point of it? What's the reason for change? And the fundamental reason is that the NHS has been very fragmented for a long period of time. And that is not in the interests of the patients, the population, people who work in the NHS, nor the taxpayer, actually. And we are now moving from a long period of time, certainly 10 years, arguably much longer, in terms of fragmentation in the health service, to one of integration. We kind of intuitively all know, don't we, that great healthcare is dependent on great teamwork, and great teamwork requires high levels of trust, partnership, and integration. It's very simple at that highest level. And when I talk, I always say that the point of having an integrated care system is not to have a system. The point is to have integrated care. And I see that through 2 dimensions. One is for the individual patient or person receiving care, that it is joined up for them, that their actual care is joined up for them. I've heard over a long period of time from many GPs, colleagues in social care, local government, the trusts, that healthcare just is not joined up for our patients, John, in Lincolnshire. And you will experience that yourselves every day, trying to communicate with colleagues, trying to organise something for patients, trying to get care in place for them, trying to get, blood tests for them, whatever it happens to be. You'll know that it is not as smooth and integrated as it could be. That's a waste of patients' time. It's a waste of your precious clinical time. So there's something about how we join up care for individual patients in an integrated way, but there's also about having an integrated approach to improving the health and well-being of the population as well as a whole. So integrated care is about how we care together and improve the health of communities in Lincolnshire, as much as how we improve the experience for patients and people working in the NHS in terms of integrating care for the patient in front of us. And that, in very high level, simple terms, is what we're shooting for. So we're moving, you'll see there the description of the fragmented healthcare system we have been, and the thriving integrated care system that we are aiming to become. And in aiming to become that, as I say, our ambition isn't just to be all right. It's to be one of the best integrated care systems in the country. Why wouldn't we want the people of Lincolnshire to be receiving some of the best care it's possible to receive in the country? Why wouldn't we want Lincolnshire to be regarded as doing great stuff in terms of rural and coastal healthcare? Why wouldn't we want Lincolnshire to be regarded as a great place to have a clinical career? You feel rewarded, supported, enabled, you've got a voice, and you can guide and advise us in terms of how we can become continuously better at providing great integrated care. So that's really what the point is, and what the ambition is for us. So I'll skip over the next couple of slides, which just say a little bit more about the fragmented healthcare system we've been and the integrated care system that we want to become. And you'll see at the top of that, the 4 bullet points at the top are the 4 core purposes of the integrated care system. And you'll see at the bottom what we think that will mean for the people of Lincolnshire. So that will be part of the pack. Who do we want to put absolutely at the heart of this system? And actually, when I was interviewed for the job, which about a year ago now, I think, I actually said this as part of my interview presentation. I said there are three sort of core components that we need to have right at the heart of our integrated care system if we're going to make a success of it. The first is the public. I think that we need to have the needs and voice of the public influencing how the healthcare system works in Lincolnshire. And it's the public, not just in terms of the health needs and the deprivation and the public health stuff, but also the relationship that we have with the people of Lincolnshire. In very, very simple terms, we should be designing and delivering healthcare with the people of Lincolnshire. We shouldn't be doing it for them, and we shouldn't be doing it to them. We should be doing it with them as a partnership. I think we've got a long way to go as a system on that. I don't think we truly understand what actually matters most to people in Lincolnshire about their health. And I do think that the NHS isn't great at engaging with the people of Lincolnshire, which isn't to say we don't try really hard and there isn't some great stuff going on. But I'm looking to our county council and our district councils, to Health Watch and to our voluntary sector, who I think are much closer to the population in terms of being understanding their needs than we are. I think we still tend to talk to, as an NHS, the population that we serve. So we're doing a lot of work to try to create a new core philosophy of it's called co-production, but in very simple terms, as we do this with the people we serve, we don't do it to them or for them. So the next core contributors are clearly all of our partners. An integrated healthcare system requires everybody to play their part, and it requires people like me and Sunil to try to make the sum of the parts greater than just the individual components. That's the magic bit, really. And you'll have heard from the way I've described the structure of the Integrated Care Board, how we work with providers, and how the Integrated Care Partnership works, that I think we've already got really strong partnership arrangements and ability to listen to the voice of partners. But I think we can do far more on that. And that's a bit of a journey of exploration, I would say. And then finally, having the clinical voice right in the middle of designing and delivering our system is so important. Clinical pathways for patients, best clinical evidence, how we're going to have great clinical careers, how we're going to support clinicians in Lincolnshire. So to do this, we've got two new arrangements just coming into place, actually, which Sunil is leading on the development of for us. The first of these is we're developing a Lincolnshire Primary Care Advisory Group. This will constitute of the four, it's all primary care, so it's not just general practice, it's our pharmacists, our ophthalmologists and our dentists as well. And so in the Primary Care Advisory Group, we will have the four professional committees, including the LMC. We will have our four what we call clinical locality leads, who are senior GPs who represent practices in their patch. We've got 4 patches, so there's 4 GPs are Dr. Dave Baker, who represents the Southwest patch, Dr. Majid Akram. Majid is a GP in Deepings, and he represents the south of the county. Dr. James Howarth, who's a GP in Spilsby, who represents the east of the county, and then finally Dr. John Parkin from the west, who represents the west. They are all on the primary care advisory group. We also will have PCN clinical directors, and there's an open invitation for first 5 GPs to become involved in our Lincolnshire primary care advisory group, and that's a conversation that I think Sonal will want to have with you, Lecky, and colleagues in terms of how we ensure that the first 5 group plays strongly into our Lincolnshire primary care advisory group. It's a new group that's just developing. The other thing I wanted to talk about was the Care and Clinical Directorate for the system, which Sonal is developing. So this isn't just about primary care. This is clinicians across all sectors of the NHS in the county, and it also includes the social care sector and public health, and the work of the clinical directorate is it's got a few things going on, but really to give us that joined up clinical advice about the best application of clinical evidence along patient pathways. So we've already been doing some work on things like colorectal cancer, stroke, urgent and emergency care, where our senior clinicians from across the system are giving us some clear clinical advice about how we can best organise ourselves in line with best clinical practice. That's really, really encouraging. The clinical directorate is also leading the development of the Lincolnshire Academy for Clinical Excellence, which is a joint piece of work with the university, because we want clinical excellence in Lincolnshire. All clinicians, not just doctors, all clinicians want to be great clinicians, and we have a responsibility, I think, as a system to support clinicians on that aspiration. So the Lincolnshire Academy of Clinical Excellence is rapidly sort of coming out of the ground, and I hope in the months and years ahead, you will remember this conversation this evening and say, well, I remember John talking about that, and now in Lincolnshire we have a brilliant Academy of Clinical Excellence, one of the best in the country. So that's really, really important. So those are the core contributors to the integrated care system in Lincolnshire. So I'm nearly there. So what matters? What people are saying matters. Well, so far they're saying that local matters. What that means is that the health needs of the people in Mablethorpe are different from the ones in Long Sutton, in Stamford and in Gainsborough, and all points in between. So whilst Lincolnshire's a quite unified county, the variation in the needs of the people we serve across Lincolnshire is considerable. The assets in the local communities are different. So what we are doing is actually trying to create great joined up integrated care in our local communities, and the footprints for that are the 15 PCN footprints. We're not going to be slave to those footprints, because some things make sense to do on a smaller footprint or a bigger footprint than the PCNs, but that's the sort of, if you like, the core building blocks. The next thing that people are saying is integration really, really matters. I'm hearing this a lot from the public and from patients as well as from clinicians. So where that takes us to is that the primary care networks are the local bit. If integration really matters, it can only really happen on a local footprint. So that means that primary care networks have a lead role in creating and enabling integration for their local communities. The next thing we're hearing is prevention is better than cure. So this actually means that we've got to more proactively manage the health of the population rather than just react to it when it all goes wrong for our communities. So that means that all of the prevention work we need to power up. So you might have seen the Know Your Numbers campaign out and about. Things like smoking, physical activity, positive mental health, all of these really good preventive measures we need to power up, and they need to be integrated with what's happening on the ground locally within the context of the PCN footprints. We're also hearing, as I've said, the relationship with the public is essential, and that clinical input and I think clinical leadership is essential as well. So whilst I talk, Lecky, about the Lincolnshire system as a whole, I almost see it as a combination of sort of micro systems, if you like, across our 15 PCN footprints, because that's where the change that we are all ambitious about will happen. Sorry, where a lot of it can only happen. Some of it can happen county-wide, but a lot of it can only happen locally. I've done it again. And just finally, so what am I really worried about at the moment? It's a lot of things. It's more than 8 boxes worth of things. I suppose these are the key things. So from top left, I'm really worried about winter. I'm really worried about urgent care. I'm worried about ambulance handover delays. I'm worried about people waiting too long in A&E. These are sick people, frail and elderly people, and I'm concerned that we are really causing distress and potentially, for some patients, creating an unsafe service. People in Lincolnshire, this is a huge concern for us all here and now. Today, I probably spend at least 1 hour every day crawling over ambulance handover delays, how many people are in A&E, all of these points. The next thing I'm worried about is workforce. We've got some brilliant people. We've got a lot of ambition, but we haven't got enough people to really do the job in Lincolnshire. We haven't for a while, and we need to address that going forward. It's stark in the NHS, but it's even starker out in social care, where people working in care homes and domiciliary care. You've heard it like I have. They're amongst the lowest paid, doing some of the most essential work in our communities, and you can get far more working for a local supermarket. That's not great, is it? Digital. There's been a bit of a success story on digital. Primary care kind of did brilliant work on digital through the pandemic, but all that showed me is how much further we've got to go, and this is part of changing the relationship with the people of Lincolnshire. I've covered the top right box. Bottom left, we're doing really great in Lincolnshire on catching up on elective care, one of the best in the country actually, in terms of how long people have to wait for their operations, but we've still got a lot more to do. Cancer performance is improving in Lincolnshire, but it's still a worry. Colorectal cancer is getting better, but it's still not where we need it to be. Other cancer sites management is on the whole pretty good. Access to primary care includes pharmacists, ophthalmologists and dentists. Getting an NHS dentist in Lincolnshire is to say it's a challenge is an understatement. So a lot of our population aren't able to access dentistry. Just think about, well, you know better than I, the impact that has on their health. And finally, addressing health inequalities. I've talked a lot about that. Look, Lecky, colleagues, thank you for that. Thank you for listening to me. I hope that's been of some interest. I'll stop sharing. Very happy to open up the conversation from there. And to bring Sonil in as well, I think, please.
Thank you so much for that, John. Very, very interesting. Made a lot of notes. I've had a lot of my colleagues have done the same thing. Thank you, Sunil. Great to have you as well with us, and with your significant level of experience and leadership. Keen to learn from you both, and also very happy that we have this recorded. So we have a few colleagues who've asked if we could have recorded this. Thank you for agreeing to that. You've covered the ICB very nicely for us, and I think going forward, people can say, we know what the ICB does, right? One of the things that keeps coming back, a few colleagues have been asking these questions on the First Five group, and specifically they've asked about waiting times, because we keep getting patients come in to us to say, we're waiting for our surgery. What can you do for us in the meantime? One of the things we do from a GP perspective is we tend to write an expedited letter if it warrants that, or we tend to try our best to manage their concerns in primary care. For an immediate answer, what is, I mean, you're doing a lot already and you've shown us all the worries you have, but what are the immediate things we are doing at the moment to help try to manage the waiting times for the main cancer to equate concerns? These are the main things that concern people. And then the next thing will be the surgeries, the main surgeries in secondary care. Are there any main things that are being done differently from what you've done in the past? Are there new strategies that have been taking place? Just wonder what your thoughts are and what we can sort of say to reassure people. I know you've already said, I'm going to end shortly, that elective care, we're doing one of the best in the country. I remember you and I spoke about those numbers right after the National RCGP conference. But just off the top of your head, are there certain things that we are doing differently due to the post-COVID experience and obviously the new change in the relationship of how we're working together to help reduce the waiting list times, specifically for cancer and surgeries?
Yeah, great question. Thank you. Okay, I'll invite Sunil to help with that. I mean, the answer is there isn't one thing we're doing. There's this very significant number of things that we're doing, all of which add up to helping us with our performance. I must say that whilst our current catch-up performance is far better than most other parts of the country, if you were to compare how many people are waiting to how many were waiting pre-COVID, I mean, it's dire. We virtually had nobody at all waiting over what was it, sort of 12 months for an operation. Yeah. We're now celebrating, if that's it, or we're not, but bigging up the fact that we now have nobody waiting more than 2 years. So whilst it's good that our performance compares well on the catch-up, for the population of Lincolnshire, compared to where we were pre-COVID, we've gone backwards a long way, and that's the case across the country as well. So Sonil, I wonder if you just might want to say a few things about what we're doing clinically around all of that, and any advice for the First Five group, please.
Yeah, no, thank you, and thank you for inviting me along. So the guy that wrote PDSA said, don't do things better, do better things. So we have to learn from COVID, and John's already mentioned about digitization. So if you look at the MSK pathway that we've just worked on, we've changed that, okay? So that you can, and your PCN can, stake up virtual clinics. So there's no referral, there isn't any of that. You sit down with the patient, or you or the FCP, the consultants on the other end, and they decide yes or no for hip surgery, or no for hip surgery or knee surgery. That cuts out outpatient, cuts out waiting times, cuts out, and it's direct listing. The only time the patient ever walks into the hospital is when they've had the day of the surgery, hopefully out again. We've also built in prehab and rehab. So if you hear prehab clinics, and Adrian, they actually happen in Grantham, we'd invite everyone on the current waiting list, and we're just beginning to roll the process out and say, here you go, you're waiting for hip surgery. This is what we can do. Let's get your physio in now, not wait until after the surgery. By doing that already, we've had at least one person saying, thank you very much, I don't need the surgery anymore, I'll just go and do what you've told me. So you see, we've got to think differently clinically about what could we do differently, but that also, and I get the frustration for you know, what can you do as general practice? Well, if we do things differently at the front end, that saves us a heck of a long time down track. Admin time, procedure time, filling in form time, all of that. So it is about, can we then replicate the model in other specialties? In terms of cancer, and you heard some of the FIT conversation, when we dug more into that, LACE is about gathering the clinical evidence, which we did, presenting it to us and saying, well, how, go on and make sense of it. And very clearly, there's an anxiety about those middle uncertain ground people. So we've now created advice and guidance specifically for that route. No 48-hour response. I'm worried about this person. Consultant, what do you think? And also an urgent colorectal clinic, as well as a 2-week wait pathway. So it's about working the point that John was making. Integrated care is about integrating care. And that really means, from my point of view, bringing you guys, secondary care, physio, whoever, together and say, what's the clinical evidence? What are the issues? How are we going to work it out? And we've got a lot of support to do that. So I would be delighted so LACE, we're just finalising, hopefully with the university, maybe even have some space with the university to get you guys involved and say, and you have probably the most recent experience of clinical evidence than people like me who've done it 30 years ago. It'd be great to get your expertise involved in that.
Excellent. Thank you so much, Sunil. And LACE, by the way, is Lincolnshire Academy of Clinical Excellence, for those getting used to the term.
Sorry.
Thank you very much, Sunil. Excellent, excellent. If it's okay, I actually want to pick up on the next point, which Adrian kind of just mentioned very briefly there, and it actually got me thinking as well. He mentioned about asylum and asylum, seekers and individuals who have moved over here with the recent change in things. How are we as the ICB, and how are we as Lincolnshire healthcare supporting these individuals? What are the support for the practices as well, to manage this? Because obviously this is an ongoing issue, and I bet it's not going to get any easier anytime soon.
No, it's a great question, Lincoln. We have been having asylum seekers in Lincolnshire for quite a period now. We have no control about the placement of asylum seekers in the county. All of that is done under the aegis of it's the Home Office, and they have an outfit called Serco who do that. And there are different kind of groups of asylum seekers who come to the country and are handled by Serco in different ways. For example, we've had a considerable number of Afghan refugees in the county, significant number in the Grantham area, actually. That has been quite different from the people who come over the channel on the boats, who are handled in a different way, and we know that they've been put up in hotels on the coast quite a lot. Now, those of you who are closer to this than I will know that very, very different needs. So, for example, the Afghan refugees aren't always, but tend more to be families. So you have a whole family unit to sort of deal with, whereas the people who come over on the boats, not always, but predominantly male, and younger men, and actually come from all different parts of the globe, really. So it's not like they're coming from one country, one religion, one culture. So there's a whole raft of really challenging issues to work our way through. And again, each of the groups, some of them are passing through in a very short-term way. Others we've had for quite a period of time. I think what we do know is that whilst some aspects of this may change, I think we can expect we'll be getting more of these people who've been through terrible trauma, of course, in our county, that puts a huge pressure on a wide range of services, not least of which obviously is general practice, as well as kind of social care services as well. So within the ICB, we do have a primary care team, and that primary care team works closely with the PCNs in particular and the practices concerned to make sure that we're doing all we can to work with the practices in terms of supporting them. We recognise this as an additional ask of practices, and it's, as I've just described, quite complex ask. So it is featuring more and more in our thinking and our planning. Sonal, I don't know if there's anything more you'd like to say, or Adrian, actually, in terms of your experience in the Grantham area. It's a tricky area all round, isn't it?
Yes, John, thank you. Got to start by saying you've got to upgrade Sunil's screensaver at the back of him now. He's still sitting with his Peace in the Lions sporting the wrong look behind him. I'm quite upset to see he's not been upgraded yet. Yeah, so as you so eloquently said, John, the challenge we've been facing is very significant. So it's a completely different kettle of fish from the Afghanistan refugees we had across 2 hotels, initially in the Grantham area, and how we dealt with them. And with the support of the CCG at the time, we set up a bespoke service where we had health screening, and then we're still going in doing two and a half days of services and clinics in their hotel. They're all in the urban hotel now in Grantham. And lo and behold, we've just all been on top of things when we got this news about Stoke Rosswood being annexed with the help of Serco for asylum seekers. Yeah, completely different kettle of fish with my general practice and GP hat on. So the challenge here is, as you so rightly say, is not just family units. These are safeguarding nightmares, if you like. You have people trafficking, modern slavery. You have disease burden. You have people who've been living rough and on the streets and in camps before they made a crossing with their own bespoke and very specific and severe health needs that's now landed on our doorstep. And of course, where the Afghanistan refugees were accepted well because of the background to them, you know, there's already been issues in our area with outcries and uprisings and security issues about the reaction to what's happened. And these people landing on doorsteps where they're mostly going to be made feel welcome by the local population. So there's already been flashpoints and issues on that front. And just to spell a few things out that illustrates how difficult this is, despite the billions the government is spending on outsourcing this to Serco, the actual funding attached to looking after one person is just £150 for initial health check. That is it. So luckily, John and the people below have been really good in supporting us and setting up a service to look after these people properly, bespokely, without overburdening general practice and the practice they've registered with. But that's more challenging with the asylum seekers than it was with the Afghanistan for those reasons I've just listed. In London, we got word of a DES that was developed, which really was a slap in the face general practice. If you think about it, there was £40 to £60 DES created to sign up. Anything up to 60 asylum seekers was a £40 one-off payment extra, and anything over 60 was a £60 extra payment. Now, just with your GP hats on, to think of the impact of these people and what they do to disease burden, our figures, our targets, immunisations, vaccines, QOF, you know, that is something that a single practice cannot absorb if you're starting looking at around 100 people. All those figures are then way skewed. And of course, these people need looking after properly and quite intensively. So it's just a big mountain ahead of us now to climb with what's going on in Stoke Rosswood on several fronts. Yeah, so tough times ahead, but we got to do something. We've got to look after them.
Thank you for that, Sunil.
Thank you, Adrian. I think you're raising a really important point here, and I wonder whether we should have a closer look at this in the round. you'll know the health inequalities agenda has something called Core 20+5. For Lincolnshire, this community will be forming part of the +5 because they are very unique, and Lincolnshire has a unique set of circumstances. So we've got a lot of people in Lincoln who are from Ukraine now, quite a lot from Afghanistan, as you've said, and they have their own needs. What we can't do is allow the difficulties that we're facing to affect their health, considering what they've been through. You know, pretty traumatic stories that you hear. You know, we had somebody who was completely unable to speak for post-traumatic stress. We've just somehow got to come together and see, is the service offer better, and not just leaving it to general practice's door and saying, here you go, you sort it for 40 quid, thank you very much. That doesn't quite sit right. But perhaps we should be working in a different model and pick that up. And you know, your input would be really valuable because you've obviously got a hell of a lot of experience in this. So perhaps we can pick that up with Sarah Jane and Sandra at some point and say, well, how are we going to address this? Because it is a health inequality in the biggest sense of the word. You're
quite right, Sunil, and there's probably not the forum to raise it, but seeing that it has been a question with me mentioning at the start. Yeah, as I said before, luckily Catherine Perrin and with support of Claire and obviously Claire Rabel and Sarah Jane have been very supportive of what we've been trying to do, especially with the Afghanistan people, but now also this new influx. And last week we were talking 60, we now have 193 people in Stoke, and that's going to go up to 240 if the full capacity of the hotel is utilised, which is what the I think what the aim will be. So yeah, significant challenge, but any input and positive contribution is appreciated, Sunil. And of course, we all know we're already on our knees. John has said earlier what struggles we have with staff retention and recruitment, and of course, there's no one sitting around, you know, twiddling their fingers in general practice, right up from admin staff to nursing staff to HCAs to GPs and ANPs to come and do this. So we are recruiting and trying to get people to do this job is increasingly challenging on top of what we're still doing at the MERS and K2. So it's a big challenge that we're facing. Yeah.
Thank you for that, and thank you, Sunil and John, for your support going forward with that. Do we have any other questions from the floor? Feel free to please type it in the chat box, or you can unmute your mics now, or you can raise your hand, whatever you prefer. While we're waiting for the questions, I just have another question, if that's okay. And this is to Sunil. Sunil, you mentioned LACE and you mentioned you're welcoming the group, the first 5 to join. How do we get in contact if we have a few members who would like to represent us on the group? Is that going to be, do I email you? Because obviously I have your contacts, or do you have any other intermediary you'd like me to reach out to?
So we are in the process of recruiting a program support structure around LACE and the clinical direction. But in the meantime, just do it through me and I will make sure that we get you hooked in. So Martin Fye, who's Director of Nursing, and John Parkin, some of you know, are leading LACE on our behalf, together with some of the university people. But it is about getting people really into the rigor of academia and supporting pathway redesign. Like perhaps at another time I can come back to you and talk to you more formally around both PCAG, which is a primary care advisory group, which is now up and running, thankfully. We had 2 meetings, and also the clinical directorate in the lounge. More than happy to do that.
Thank you so much, Sunil. Adrian, you had a question there.
Yeah, so that was a Freudian slip. I thought I had my hand up from before, was going to lower it and raise it again. So showing that age. Similar issues with John with pressing the wrong button, I think.
That's all right. Any other final questions before we let our lovely speakers rest for the evening? I'll just give everyone a few seconds to collect their thoughts. It's been an excellent talk. Thank you so much. I have lots of notes. If you'd like, I can share my notes with you. This is to the first 5 group. Otherwise, you can watch the recording afterwards. Again, thank you. They may develop questions later on. So if that's okay, is it all right to email some burning questions to you, Sunil and John? Is that okay? Excellent.
welcome,
Thank you
yeah.
so much. Because that tends to occur when we tend to just assimilate this and let it simmer. So thanks again. We look forward to inviting you back. It's been an excellent meeting. People have trickled in and now our numbers have swollen. So it's been a true pleasure. And I just want to say, great work and thank you. Any final thoughts for the group, for the first 5 group before you leave us tonight? John and Sunil?
Just from my perspective, like we have an ongoing relationship, so I see this as just part of that ongoing development. And thank you for giving me the opportunity to speak with you all. I hope that what you've a key message that I want you to all take on board is that the health and care system in Lincolnshire now and in the future is your system as much as mine, and we've got a great first 5 group. I mentioned that right at the top of the meeting. We see you as core part of our system, our integrated care system. So the door is absolutely open for you to become involved in the system in the way that you would feel would best suit the needs of the group. I certainly think a conversation with Sunil about both the Primary Care Advisory Group, the Care and Clinical Directorate, the Lincolnshire Academy of Clinical Excellence will be very fruitful for you, so we can build your input, your voice, your aspirations in clinical terms into that. Obviously, the work we're doing around GP fellows, which like you Ola and I talk about a lot, we're in the process of expanding that, aren't we? And we want to continue to back that and develop that in Lincolnshire. And I expect, Sunil, as that evolves, that might be something that sort of is under the umbrella of the Lincolnshire Academy of Clinical Excellence. So lots of opportunities going forward for us to really, further deepen, develop and grow the relationship between obviously it's not between, is it? You're part of first 5 within the system. So thanks again for having me. I hope it's been of some help. Sunil, would you like to make any final comments?
Yeah, I echo what John said. We come across many systems, and trust me, guys, you are way ahead in terms of the first 5 group, way ahead in terms of membership and the way you've come together. And so, sometimes in the NHS, we always seem to focus on the negative, but this is a real positive. So a few moments to reflect on the positivity is great. And you guys are the future. It's not guys like me. So we really do want to bring you into whatever forum you feel comfortable with. And certainly LACE and Clinical Director, absolutely, your experience is going to be vital. And just on the fellowship bit, just as an example, we're trying to look at a research fellowship so you can spend some time in the university with Neeru and his team, as well as doing the clinical practice, if that is your bag. So the more we can extend that portfolio, the better it is. And certainly from my point of view as MD, we want the best that we can be in terms of our performance, in terms of our academia, in terms of opportunity to develop. Why wouldn't we? And we're trying to get to a university hospital status, and I hope that will come in due course. That will be when we can really say we've gone a long way. But thanks again, it's really helpful.
Thank you so much. Excellent. So we'll conclude the meeting at this point. See you very soon, Sunil and John, and catch you around.
Thanks,
everyone.
Thanks.
Cheers.
Bye.
Thank you. Bye-bye. Bye.
Well done, Leke.
Oh, thank you for your support, Ola, as always. My internet started acting up quite at the end. Let me just stop this recording before I continue. Stop recording.